So basically, when you think of cerebral small vessel disease, I want you to think of endothelial dysfunction. And so that's ultimately what we're talking about. So there's a lot of things that can cause endothelial dysfunction and end in cerebral microvascular disease. So arteriolosclerosis is one of those things. And so that is when there's thickening and stiffness in the little tiny arteries in the brain. It could be other places too, but we're talking about in the brain. And so anywhere it happens, but also in the brain, it's caused by hypertension in part. So hypertension is one of those things that has to be addressed if you have that. Another cause of the cerebral microvascular disease is deposition of the beta amyloid plaques, like you'll see in a cerebral amyloid angiopathy. Another cause of cerebral microvascular disease is blood-brain barrier breach and also activation of microglia, which become inflammatory when they're turned on and firing all the time. What we know too is that women are at increased risk for cerebral microvascular disease when compared to men. We know that women are at greater risk for cognitive impairment after the strokes that are caused by cerebral microvascular disease, and that women's reproductive history is not predictive of cerebral microvascular disease. So it doesn't matter if you had preeclampsia or eclampsia or any kind of how many babies you had, how many miscarriages you had, those things are not predictive. What is predictive is the total number of years that you had exposure to your own female hormones. That decreases the risk of cerebral microvascular disease. So if you went through menopause early, or if you went through menarche late, those would be increased risk factors for cerebral microvascular disease. Another interesting fact is that women on hormone replacement therapy tend to do better postmenopausally with their cerebral vascular function than do women who do not go on hormone replacement therapy. And this reactivity or responsivity of the cerebral microvasculature continues even after stopping hormone replacement therapy. And we're really talking in particular about estrogen. That has more of an impact than progesterone does. So hypertension, one of the risk factors for cerebral microvascular disease. And hypertension is not just one thing. It can be caused by many different things. It can be caused by something happening in the heart, something happening with the kidney, something happening in the endocrine system, like the thyroid. It can be an issue with the autonomic or the central nervous system, particularly if there's sympathetic dominance. And so when we're talking about hypertension, we're not speaking globally. We really have to dive in and understand why that person has hypertension and address that underlying issue. And that underlying issue of what causes hypertension has changed over time and become more and more elaborate, so that now we understand there's also genetic components, there's environmental components, there's anatomical components. And so we want to be careful when we're working up hypertension. So we've mentioned quite a few of the causes. Other ones have to do with that renin-angiotensin-aldosterone system. That's the one that's related to salt. And so a lot of times, your doctor will tell you decrease your salt intake. And that will help folks who have problems with this system, but maybe not everybody else. being overweight or obese, having metabolic syndrome, which often go together, are also causes of hypertension and would probably have a different sort of intervention. A sleep apnea would have its own particular intervention. And then we talked about chronic kidney disease or thyroid problems that would also need to be worked up and addressed. Beta amyloid plaques are one of the causes for small vessel disease in the brain. So what most people think of when they think of beta amyloid plaques is Alzheimer's, but they can actually be around for other things too. And amyloid beta is actually a normal part of the brain. It's produced by the astrocytes, the neurons, the skin, the skeletal muscle, so it exists outside of the brain, intestinal epithelium, and it's even a type of biofilm that's used by bacteria at times. So what it's supposed to do is protect us from infections. And actually 11 microorganisms have been identified that amyloid beta attacks. Amyloid beta also suppresses tumor growth, helps to repair a leaky blood-brain barrier, promote recovery from brain injury, hypoxia, and autoimmune disease. It helps to regulate glutamine and acetylcholine and balance the autonomic nervous system. And it contributes to memory consolidation. So it's really important for our brain. So we should make it, we should use it, and then it should be excreted. It's supposed to be excreted by the kidney, the liver, the gastrointestinal tract, and the skin. But sometimes there's a problem. Sometimes there's accumulation of beta amyloid, and that can lead to plaquing. So the reasons that you can have these accumulation and plaquing is because of incorrect pruning of the amyloid precursor protein called APP, incorrect function of that same amyloid precursor protein, or incorrect function of insulin degrading enzyme. What is amyloid precursor protein? It is expressed in the endothelial cells of the microvasculature of the brain. And it's supposed to be pruned by alpha secretase and gamma secretase, and to be pruned down to a peptide chain that's about 38 peptides long. And when this happens, you won't have any amyloid plaques formed. However, if beta secretase is active and gamma secretase is mutated, then you're going to not get the right pruning of the amyloid precursor protein. And you will get a strand that is too long. That's 42 peptides long. Can you believe it? Just 4 peptides longer makes a huge difference. When this happens, then you are going to be at risk of plaquing when that longer peptide chain interacts with chronic inflammation and the apolipoprotein E. We know that the apolipoprotein E 4, when you have a variant or a SNP where you have dominance of 4, then that in particular is what increases risk for plaquing. So here we go. So apolipoprotein, so the amyloid precursor protein is a glycoprotein, and this is what's supposed to happen normally. So on the left, normal. So here you have alpha secretase comes in. There you have your amyloid beta. The alpha secretase, that's an enzyme, right? So it digests, it cuts. So it cuts that shorter that amyloid precursor protein. And there's gamma secretase comes in and helps out. And then we do not end up with a long chain. and we all live happily ever after. However, if we have beta secretase come in to that amyloid beta and cut it, then we're getting this longer peptide chain. We're getting the gamma secretase and maybe even the mutation there. And then we're ending up with amyloid beta as a result, and that in the presence of inflammation can cause plaquing. So beta secretase is activated by oxidative stress. So if you have that oxidative stress, then that is what sets you up to get that amyloid beta plaquing. Low estrogen also sets you up because that would be higher inflammation also, and the less dilation of the vessels, and there's a number of reasons. And then also if you have improper exposure to metals. So if you have a high copper or iron and a low zinc, those all set you up for that amyloid precursor protein not to function properly. So insulin degrading enzyme is another component that influences amyloid beta. Amyloid beta plaques, let's say you do have that beta secretase activated because you have oxidative stress and you do have inflammation and you do get a plaque. Well, there's still hope. So what's supposed to happen is that insulin degrading enzyme is supposed to come in and clean that up in part. However, insulin degrading enzyme really wants to take care of insulin, as its name implies. So that if there's any insulin hanging out, then it's going to focus on breaking down that insulin instead of the amyloid beta plaques. And, insulin is also highly inflammatory. And so it's not wrong that the insulin degrading enzyme wants to break down insulin. It's good, but it just doesn't have enough energy to be able to also take care of the plaques. And so what we really need to do is to be careful about sugar and insulin and to make sure that those are minimal in our body, that we don't get insulin resistance, because when you have insulin resistance, that's what causes your body to release more insulin. And that's what makes the insulin degrading enzyme not be able to do its regular job of cleaning up those amyloid beta plaques if they're formed. So if you do get the amyloid plaques, then they can block the ion channels, disrupt calcium homeostasis, dysregulate energy and glucose metabolism, cause mitochondrial oxidative stress, and program death of the nerves, and result in poor microvascularization. So if you do have buildup of plaque in the small vessels, that will impair endothelial function. It will create even more oxidative stress. You will have the vascular smooth muscle cell dysfunction and chronic inflammation. Now, what happens in the blood-brain barrier? So the blood-brain barrier is a semi-permeable membrane between the blood and the interstitium of the brain, or like the brain matter, you can say. So most people nowadays have heard about leaky gut, right? So that's where the semi-permeable membrane of the gut is breached and molecules are getting in and out that shouldn't. Well, the same thing can happen in the brain, right? So in the brain, we have physical barrier that's called tight junctions. And we also have a metabolic or chemical barrier. Both of those things are what help to keep the brain sealed, the blood-brain barrier intact. So the tight junctions go between the endothelial cells, and the like we'll see in another picture, and we talked about before, the pericytes help to kind of stabilize, and the capillary basement membrane helps to stabilize, so that keep those tight junctions in place, as well as the astrocyte end feet. The chemical or metabolic barrier is related to the neurotransmitter metabolizing enzymes like MAO, GABA, the endopeptidases, and also related to the drug or toxin detoxifying enzymes like the CYP450, GGT, and ALP. And everybody's goal, whether it's the physical, the mechanical tight junctions, or the chemical metabolic barrier, that combined goal is to prevent toxic substances from entering the brain. So when it's breached, then we're going to get in, those heavy metals or those microorganisms that cause infections, and other things too. So here's a picture of the blood-brain barrier. Here's the brain in the blue on top, and on the bottom is the blood in the kind of brown. And then in the middle, we have the endothelial cells, those bricks. So here we have the tight junctures that are formed when the pericyte is there to stabilize, the basement membrane is there, and the astrocyte end feet are there to stabilize that whole process. Then we can say nice and sealed up, semi-permeable. Microglia activation is another reason another risk factor for microvascular dysfunction in the brain. So the microglia are the immune cells in the brain. They're macrophages, and macrophage, when it's found in the brain, is called microglia. They regulate capillary vascular tone. They're involved with synapse pruning and regulation of the neurons, and helping to clear cellular and toxic debris. So, however, if they're turned on and they don't turn off, instead of being helpful in all of these processes, they will become inflammatory themselves and contribute to inflammation and stop doing all these jobs. So microvascular disease, again, causes reduced blood flow, microvascular angina, or kind of like spasming, and organ damage because the blood isn't getting there, and it's not, and the veins, so the nutrient-rich, oxygen-rich blood is not getting to the end organ, and the veins are not taking away the toxins or the debris. Again, cerebral microvascular disease is endothelial dysfunction. So what we talked about, some of the big causes of endothelial dysfunction. Now we want to kind of start taking a little bit of a closer look. Endothelial dysfunction can be caused by deficiencies in the production of nitric oxide in the L-arginine pathway. This is the primary pathway to produce nitric oxide, which is vasodilatory, and it is the only pathway to produce nitric oxide in the brain. We also have mechanical damage to the endothelium caused by hypertension, mechanical damage to the endothelium caused by amyloid plaquing, and inflammatory damage to the endothelium caused by leaky blood-brain barrier and those activated microglia that don't turn off and cause inflammation.